I don't think that was the case of that trial, but you're also right. In the book that none of you have read on randomised trials, we also say...
I read the book.
Oh, no, you didn't. No, I didn't. I know you're lying through your teeth there. One swallow doesn't make a summer, and I agree. One would like to see more studies, bigger studies, etc. We always say that. The problem is these are very expensive to do, and they are effing difficult. The amount of negotiation to randomise people to different legal outcomes, which is what we're talking about, took years to negotiate and was a very brave thing to do. I'm not sure there ever will be another study, and I'm not sure that the normal way we procrastinate and say we need more research, i.e. give me more money to do better trials, I doubt that's going to happen. I think we have the best evidence that we have now. I don't think it's going to get any better.
I'll go out to the audience and then I will come back.
Well, of course we do deem the vast majority of people with mental disorders to have autonomy. Last year, 960,000, sorry, 1 million, I'm going to round up. 1 million people have been treated by our secondary mental health services. That's not including everyone treated outside them, the 4 million people in general practice and so on and so forth, 1 million. Of those, 20,000 are subject to some form of mental health act and 4,000 are subject to CTOs. So the vast majority of people with mental disorders have full autonomy, are in the community, make all the decisions, even when we disagree with them. And even when we disagree with them, we have to accept that, just as we do with other disorders. But all civilized societies always accept there's a small number, and it is a small number, for who don't have autonomy and who don't have capacity. And that's what the mental illness, it's complicated because we have a capacity act as well. But basically, fundamentally, those are the people who are clearly ill under any system. It doesn't matter. And diagnosis isn't the issue. These are very easy to diagnose. I mean, for once, psychiatrists, even psychiatrists are in agreement about that. It's about how you treat them that's difficult, but diagnosis is rarely an issue. We agree that it is what a humane society does, is treat people in order to improve their health. The purpose is not to prevent suicide, it's not to prevent homicide either, by the way. We're not very good at that. But we are quite good at helping some people to get back to health, and that's what mental health acts are for. And, but on this particular bit of the act, the CTO bit, it's as simple for me. I have no problems with treating people in the community under a CTO if it could be shown it keeps people out of hospital, which is the least restrictive option. I don't want people to go to hospital if we can do it better in the community.
Simon.
Okay, well, if you look at what people think about CTOs, psychiatrists generally like them in most of the legislations where they're used. Relatives and families generally like them, but complain that they're not accompanied by adequate community resources, which was the promise when they came in, and patients generally don't like them. So that's the general way that they are. Having said that, there's no evidence that they're making people worse, because if what you said was true, you might expect them to be more relapse on people who are taking CTOs and more incidents and more recalls to hospital. It's exactly the same. They just have no effect. And that comes back to why I think we should move on then, because if we follow the principle of the least restrictive alternative, the other alternative, which is not to have people under a mental health act in the community, is less restrictive than having them under a CTO. And as there seems to be no difference, the default position should be the least restrictive alternative. On the question of education, boy, are you right. It drives me mad that, this is in my book, of course, which no one buys or reads, but you would think by now the simplest thing that educationalists would have sorted out is how to make little kids read, wouldn't you? You would think every year 400,000 kids learn to read at varying speeds, etc. If ever there was an area for randomized controlled trials so we could finally settle that once and for all, it would have been done in education. There haven't been any randomized trials in that. I think it's pathetic. And I think that, and I think one of the things about being in the medical profession, I have to say, and this may sound slightly elitist, but I do think it is the adherence to evidence and the ability to change your mind when the evidence changes. That's what makes you a professional, and that's why we still score reasonably highly in the public trust, because I think people realize that when the evidence changes, we change. And I think we have just the same obligation in psychiatry as they do in surgery or medicine, all the other things. The evidence has changed. CTOs sound like a good idea. 1 year ago, I would have supported them. The evidence has changed, the trial's changed, and now I can't do that any longer.
Thank you. What I'm going to do now is go to closing remarks, starting with Simon.
First of all, Tony's right that mental disorders do have an association with violence. My PhD was on when I was sharing an office with you. You obviously didn't read it, did you? No, you did read it. That's right, you said that. It's not great, actually. The risk to themselves is far greater, but it is there, and it is mediated by illness factors. That's why we have access to one of the reasons why we do occasionally have to use coercion in the treatment of those with severe mental disorders. But I remind you, it's a very small part of what psychiatry does. It's important, but it's small. Second, to the second point, in general, most people don't like the idea of putting people with mental disorders in prison. They just don't. Maybe they're wrong not to like it, but they don't. No, you can't come back. But in general, I'm sorry, that's why I'm here and I've got the mic. Hard, tough, but there we are. In general, that's not what people like. It's not what we like. It's not what Royal College like. It's just not what we try and do. It happens, of course it does. But in general, we do our best to reduce that and not increase it. On the issue of the Burns trial, remember, it wasn't about reducing violence, it was about reducing admissions. In fact, there wasn't an impact on violence, but that's not the purpose of a CTO, it is to reduce admissions. So even if it had found a reduction or an increase in violence, that wasn't the purpose of the study. In fact, it didn't make any difference. And then I suppose, on the final point, the truth is, yeah, one of the greatest enemies of progress, I'm afraid, is that doctors, like everyone else, always think that what they do does good. You wouldn't be a doctor otherwise. And in general, that's right, because you deal with most people get better most of the time. Okay, and that's why people like doctors, and that's why doctors like being doctors, because in general, most people get better. And if all we ever did was listen to doctors saying, look, I don't care, I'm pretty sure I'm doing a good job, I should be left alone, we would never make progress. Unfortunately, doctors, like everyone else, are also wrong. That's why we do have evidence, that's why we have the book that you haven't read, but that's why we do things like that, because if we just listen to doctors saying, I do the right thing, we'd still be using leeches, we'd still be bleeding, we'd still be giving schizophrenics insulin coma. That was the first trial done in psychiatry, and we were the first profession who actually radically changed our practice as a result of a trial that showed giving insulin coma in 1954 to schizophrenics was killing them quicker than it was curing them. And we stopped, and so we should with CTOs.
Thank you.